everyone. Hello, everyone. Thank you for coming to SLIM. My name is Rita Sharon. I'm a general internist, and I've been working a lot with the different schools here to help us all to learn what one another does. Because we know that in a medical center, in a health center, with a nursing school, a dental school, a chaplaincy program, a physical therapy, occupational therapy, a nutrition, a medical school, a school of public health, that we don't often have opportunities, not just to kind of work in parallel, but really come to know something about what we ourselves bring to the work of the care of the sick, and how we can come to understand what our colleagues do, whose training is very, very unlike ours. We've been doing some seminars. Some of you have been part of the NACI seminars that bring students together to learn aspects of healthcare that don't belong to any one discipline. But starting this year, we're launching many, many different kinds of exposures that students here have to one another, through which they can learn about the different aspects, the different contributions to the care of someone in hospital, in ICU, in a clinic, at home care, in hospice, so that each of us can simply get more done for patients and families. We also know, being realists, and in New York, to be a realist is a little to be a cynic, that there are vexed relationships between the disciplines. And there's lots of history, and there's lots of hierarchy, and there's lots of calcified silos. And those of us who have been in this work for a very long time can have a hard time overcoming some of the calcification, so that by having opportunities for you all to learn kind of from the beginning and as it unfolds, we're hoping that you develop and then teach us much more powerful, egalitarian, just ways of contributing to the team. So you're going to do an exercise with Dr. Sideli and his group starting at 5:15, wherein you actually go into a clinical case and figure out what would the different roles do, what would they be responsible for in this clinical case. So that we've assembled, and we're so grateful to those of you who volunteered your time here, we've assembled professionals from the disciplines of, we have here a pharmacist, a medical student, a clinical nurse specialist, a nurse practitioner, a medical resident. We saved the very last chair for you, knowing of all of us you'd be the latest. A social worker and a care manager. And these are roles that will be important in the clinical small group work that you do. So I will introduce each person with their discipline. I've given each of them only 5 minutes, to begin to help you understand what their training is, what their discipline is most responsible for in a team care of a patient. So let me start with Amy Zirba, who is the pharmacist.
Good afternoon, everyone. My name is Amy Zirba, and my education consists of 6 years of pharmacy school, and you end up with a doctor of pharmacy at that point. And then I extended my education to do 2 years of residency, very much like how medicine residents do residency. My first year of residency took me to Atlanta, Georgia, followed by a second-year residency, of which I specialized in ICU medicine out in Seattle, Washington. And so my job is a little bit different than what you probably would imagine a typical pharmacist. I don't dispense any medications. I don't check any medications. I actually am out on the floor, rounding with the teams every day. And I've worked for 15 years as a clinical pharmacist in the medical ICU. So I help the physicians or the nurse practitioners, because we actually have a nurse practitioner ICU, and I help them manage medication. So we talk about all the drug interactions. We talk about which medication is going to be best for the patient given their comorbidities. Should they go into renal failure or liver failure, we adjust those medications or pick something that might be better for that patient.
Wonderful. Thank you. Jonah Rubin. It only says medical student.
That's all I am. So I'm Jonah Rubin. I'm a fourth year at PNS, so I guess that gives me like 15 years to go. I did my undergrad at Yeshiva University, which is about 20 blocks north. I came straight here. I would say like half the class comes straight from college, and the other half probably spent a year or two doing research or in something completely different before seeing the light and doing their post-bac and joining us here. For the first year and a half, we're just in a classroom, mainly this classroom actually, and you learn basically most of medical stuff in theory until then suddenly you're thrust into the wards, which is when you guys get to see us.
Mm-hmm.
And this is right. Oh, cool. And so on the wards, we're basically like a pseudo-intern, I would say. So interns are usually taking care of, let's say, up to 10 patients at once, and medical students are probably taking care of maybe 2 to 4. But your job is really to do everything from interviewing the patient as soon as they come in, doing the physical exam, coming up with an assessment and plan, writing a note, presenting the patient the next morning on rounds to the attending and the 50 other people who are rounding with you, and then following the patient up every day throughout the course of their hospitalization. You take them to their studies, you talk to them. Often you're the only one who really has the time to get to know the patient, because if the intern's seeing 10 patients and you're seeing 4, math dictates that you have more time. But that's not to say that you have a lot of time. I think one of the challenges as a medical student is that in addition to all your responsibilities on the wards, at the same time you're also being pulled away for didactics and for other presentations you have to give, other small groups. You have to tell your resident that you're leaving. They start thinking you're making them up, maybe. But at the same time, you're still responsible to know everything that's been going on in your patient in the meantime. And I think that is definitely one of like the larger challenges that you have, because you don't want to bother your resident every 5 minutes to ask them for the updates. You're supposed to be giving them the updates yourself. And another part of this challenge is that every 6 weeks you're just thrown into a new service which you don't know. So we meet nurses who've been there for 10 years and they know everything, and then we come asking the most ridiculous, stupid questions like, where is the supply closet? And it's obviously frustrating. It must be frustrating for the nurses, but we always very much appreciate any help, and it's not just where the supply closets are. We get a lot of medical training from the nurses too. I was taught how to do my blood draws through the nurses, but they also know a lot more about treating the patients, which is helpful, because on rounds, while you're also doing all this research and you're also being taught and you're expected to have what to learn, there also are very high expectations, and you're being graded, and you're expected to meet a certain minimum standard of clinical knowledge on your own, and nurses always help us out there too. One of the final challenges, I would say, to being a medical student in the transition from your preclinical curriculum to the wards is that for the first time for all of us in our educational careers, our education is not our institutions and even not our own top priority. Suddenly it's the patients who matter more, and at times you feel initially that you're sacrificing your own education by your own leisure time or your own didactic sessions by spending more time with the patient and just seeing how they're doing or taking them to a test, and you feel like you're wasting your time. You have this chronic sense of time pressure because you also have a shelf exam at the end of the course. But the silver lining is that more often, almost every time you do that, you ultimately discover that your experience there is actually more impactful than this experiences you are missing. And I think that's brief enough. I have 5 minutes. I'll pass it on.
Thank you. Colleen McCarthy is a clinical nurse specialist.
Good afternoon. Colleen McCarthy. I work in CHONI on Fort Tower, which is pediatric med-surg, GI, and transplant. And I was a bedside nurse on the same floor for 9 years. And then I got my master's degree. I actually got my pediatric nurse practitioner, but I'm working as a clinical nurse specialist. And I've been in this role for 4 years. And a lot of people don't know what a clinical nurse specialist is. The way I describe it is I'm like Olivia Pope on Scandal, and I just fix problems all day long. I'm a fixer. So I work on a lot of quality projects I work very closely with the chief residents. I worked with Logan, your classmate, on a project that we had very good results. I do a quality meeting once a month with the chiefs, and we do it for med students, residents, and nurses together. It's very collaborative. We have a really good working relationship. I handle all the orientation for the new nurses on my floor. I round every day with Erica. who's a care manager and a social worker. We round on every patient and we try to identify any barriers for discharge. So if there's any educational issues that the family needs teaching on, they're going home with a line or a tube or a BiPAP machine, and they're not comfortable, the education hasn't been done, I'll do that education to try to speed up discharge and get them discharged quickly. I don't know, I do so many things, it's hard to think about. What else do we do? We have interdisciplinary rounds. It's a very collaborative group on Fort Tower.
What really makes you feel like if I had not been here today, disaster would have struck?
Well, I respond to all the RRTs and arrests on my floor.
What's a RRT?
Rapid response. So I try to help the nurses in those situations.
Mm-hmm.
And I also do a week of nights a month because my heart is with the night staff. I worked nights for 9 years, and I know that there's not a lot of resources at night. So that's probably my favorite week out of the month because new grads go to nights right away. So it's a lot of new nurses. It's not a lot of senior nurses, and they need help.
Yeah.
They need resources. So that's my favorite week of the month.
Fantastic. The teacher in you. Lois Braffman is a nurse practitioner.
Hi, welcome. Can everybody hear me? I have like the lowest voice ever known. You can all hear me?
2 mics.
You can imagine my patients who are hard of hearing. They get very frightened. Anyway, I have a bachelor's degree in nursing, and I got my RN at the same time, and then I have a master's degree in nursing, and I am a nurse practitioner in women's health, although I'm board certified in oncology. In the time that I've been working, it's classic story of nursing. I did everything: pediatric nursing, labor and delivery, was a Lamaze instructor, taught nursing, and all of those things kind of just add up to your experience and to your abilities. I've been at Columbia for 16 years, and I work in an oncology outpatient practice. It's primarily breast oncology, and we do a lot of clinical research. I work with 4 or 5 medical oncologists, and there are 3 NPs that work. What are our responsibilities? Basically all the medical and nursing needs of the patients, which I think is it really encompasses a lot. We see all of our patients. You have to mention these are women who have been diagnosed with breast cancer. They may be pre-surgical or post-surgical, and basically we organize their treatment plan for them. So we see the patients initially, we see them in follow-up, and then we really have the pleasure of watching them in follow-up after treatment. And as people know, breast cancer patients on the whole usually do very well. So there are women that I see in follow-up for many years after their treatment. And then it becomes really more, we're looking at long-term effects of chemotherapy, but it's really women's health issues.
Yeah.
So we do a lot of things. We write prescriptions and we write orders. We order tests and we look at them, review them with the patient. We certainly teach them about chemotherapy, about supportive measures, and then in women's health about prevention, diet, nutrition, and exercise. We're pretty busy. Sometimes we have to deal with insurance issues, which I wish we could give to somebody else. But these are like prior authorizations, pre-certifications, oh my goodness. And just trying to get tests done and get past insurance companies. Anyway, we also deal with their social issues and are so grateful when we have a social worker to refer the patients to. What do I enjoy most? Really working with the patients. I mean, the patients are really amazing. Sometimes people say, how do you work in oncology? The patients are just amazing. And it's really heartwarming to help people get through a very difficult point in their life. And I also work with great staff. I mean, I think from the physicians to the patient service representatives, everybody is really giving 120% and working hard. What's the most difficult part? Patient volume. We have a tremendous patient volume, unfortunately, and that really takes away from what I feel is like the best care we could possibly give. And also it makes for communication. I mean, you really have to try very hard to keep up with all those patients and make sure that nobody falls through the cracks. And that's really the challenge, you know, is the patient volume and then being able to communicate.
Thank you. Elana Klinger-Rogers is a social worker.
Hi, good afternoon. So my name is Ilana, and a lot of what I will say does reflect on a lot of what was just said. So in terms of educational background, I have a Master's of Science in Social Work from Columbia. It's a 2-year master's program, but what I really enjoy about this social work program that few other disciplines offer is while you're taking a full course load, you do a field placement or an internship 3 days a week in a different setting each year. So my second year I was actually placed in CHONI in the pediatric oncology unit. So that was my first foray into this hospital setting. And then now I have been, 2 years I've been in Milstein. I've in the heart surgery department. I'm in the step-down unit. So after patients have heart surgery and they are stable from the ICU, they come to my unit. So my job mostly, everything, but it mostly falls under 2 categories. So on the one hand, a lot of it is the emotional support. Understanding the psychosocial aspects of illness and what the hospitalization, the emotions that may provoke in patients. So really just sitting with them and working through, like I said, that experience of being ill. And sometimes it's not just treating, because a lot of times medically we focus a lot on treating. So my job, I try to rein it back a little bit sometimes. And remember, it's not always about treating, it's about meeting the patient where they are and how are you processing this experience. The other large component of my job is discharge planning. So although I am part of a large interdisciplinary team and we certainly all make our recommendations and make sure that the discharge plan is safe, I am the one doing all the, a lot of the logistical details. So if patients are going home, I'm setting up the services at home, making sure they have a way to get home, and all the supplies they might need. If they need an inpatient rehab stay, I'm the one that facilitates that. I get the insurance authorization, a lot of fun discharge planning. I would say, again, very similar to what's been said, really what I love the most are the people. The patients are phenomenal, and they just make every day worth it. And I have to say, my team, I've been really fortunate to be on our unit is known as getting along really well together. So it's really wonderful that, the nurses, it's a PA-driven floor, not an NP-driven floor, but the PAs, the nurses, myself, we all very much, support each other and respect each other's unique disciplines and, fortes, and I think that really plays a lot into the success of our unit.
How did that come to be? How did that respect among your team members come to be?
It's difficult to say because it's certainly a process, but I think it's how you present yourself. So when I was new, I was very nervous and I was the newbie on the floor. But I think it's partially personality and also, I think just the way I presented myself is I'm eager to jump in, and I think as soon as you demonstrate your respect for another individual, hopefully they will, that will come back to you. But I think it's just over the course of months of working together and working through many problems together, it's like it's there or it's not. So, of course, with that being said, a big challenge is with there being so many different individuals playing into a patient's care, oftentimes I really do have to play the role of an advocate, which many disciplines do. But a lot of times I feel like if the patient doesn't know who to go to or if it's anything non-medically related, they say, oh, I'll go to the social worker, even if it's nothing that really falls under my expertise. So a lot of times it's just troubleshooting problems. It's tracking people down, just getting patients in contact with the right people. So it's acting as a liaison a lot of the time. And again, the patient volume is the time constraints are really what I would say has been the most difficult. Trying to balance taking care of your patients, but really giving them your all and giving them, really the best plan for them. And also maintaining some self-care, which I think is important for all of us to be aware of, and you can't take care of yourself. It's difficult to give that to others. So.
Right. Thank you. Erica Henderson is a care manager.
Hello, everyone. Good evening. Like she said, my name is Erica Henderson, and I'm a care manager on Ford Tower, which is on, my colleague Colleen said, the medicine unit, ortho, GI, urology, small intestinal transplant, liver transplant, just a little bit of everything. My educational background, I am a nurse and have my bachelor's in nursing. However, most care managers at my level do our masters prepared. We are primarily responsible for facilitating and coordinating care activities. We're monitoring patient progress and reviewing the patient condition and making sure they meet criteria for the hospitalization. We are in constant communication with our social workers, actually share an office with the social workers, because we are the care coordination team. We share an office, and we're constantly, as Colleen said, trying to fix problems and get our Olivia Pope on. I often reflect, being away from the bedside after, I don't know, I've been a nurse now 15 years, if this position isn't aligned with my passion and the reason that I became a nurse. And I do really enjoy influencing care in a different way. It's so wonderful to see my patients and families transition home feeling safe and secure about that. And the fact that I played a part in that really reminds me, why I became a nurse and why I'm doing what I do. I would say my greatest challenge is that culture change, and we're change agents. And so trying to get my physician partners to think about dispo planning on the day of admission and not just focus on the acute hospitalization. We have to start looking at the fact that the patients are going to be transitioning home and all that goes into that. I really enjoy the opportunity to educate our residents on interdisciplinary care. We actually do a Meet Your Healthcare team every year. This is our third year, and we have a panel consisting of, Colleen did it last year, myself, PT, OT, speech, dietitian, social work, a bedside RN, and also our medical director is present as well, and we talk about our roles, but we do it in using a case study and how we would all come in and participate in the role of transitioning the patient home, and that's one of the things that I really enjoy.
Hi, everybody. My name is
Jesse Yang is a medical resident who took his time away from what he's ordinarily doing now.
Thank you, Dr. Schroen. Sorry, I was just finishing up some patient care in clinic right before this. So, my name is Jesse. My training is what Jonah is currently going through right now. So, 4 years of undergrad, 4 years of medical school. Now in my third year of medical residency, going on to fellowship next year in cardiology. So first off, quick question: how many people in here, like, quick show of hands, watch football or have any idea what football is all about? Okay, so decent number. Okay. Because otherwise, my analogy that I'm going to use next is not going to make any sense for you. So I think that my role as a medical resident, really, I'm technically the doctor on the team, but quite honestly, I'm much more the quarterback for the team. Now, there's a couple of very specific differences here. One, I don't get paid the most on the team. I am certainly not like the quarterbacks which you're used to. My pay is usually probably the lowest on the team as a medical resident. My job is not nearly as glamorous as being the quarterback on the team. And then additionally, my hair is typically not as good as Tom Brady's for the most part. But the way that I am the quarterback for the team is that if you think about the other members of the team as other members who are on an offense, for example, in many ways, the nurses and a lot of like the respiratory therapists and such, physical therapy, those are kind of like the linemen who are essentially in a way protecting the quarterback. And what do I mean by this is really that, if you don't trust your nurses and if you don't work well with them, you're going to get killed as the quarterback every single time, because they're there on the front lines, they're dealing with all of the patient care, so that, hopefully you can kind of coordinate the rest of what's going on with the patient, which means kind of, so to speak, to continue to use this analogy, getting the ball to your care coordinators, to your social workers, to your pharmacists, to try and coordinate everything that's going on in terms of, the ultimate goal is to get your patient better and to get them home again. And so I really think that, and keep in mind that the way that the attending works in all this is that they're the coach. And so when things go bad, it's usually my fault as the quarterback, as that typically happens on, Monday when people are judging. When things go well, occasionally it's my glory, but for the most part it's usually attending or the owner or something like that who's getting it. But the important distinction is that I certainly learned a lot of medicine, and I learned a lot of clinical knowledge while I was in medical school. But really the skill that I use the most on a daily basis, and I know this sounds canned, but it's quite honestly communication. The ability to make a great diagnosis or a great medical decision, quite honestly, it comes up maybe around 5% of the time that I'll do something that might actually really change patient care, usually in the setting of an emergency. But for the most part, most of the decisions which you make are going to be things which are being discussed together as a team. And so quite honestly, all that medical knowledge that I have, it's great, and it's really nice because I can impress people on rounds every now and then. But the most important thing for me is really just the ability to communicate, and being able to communicate, with the social workers, with the nurses, with the pharmacists, and have people to communicate with each other, because honestly, you're kind of the linchpin. You're the one who carries the pager as the medical resident. Everybody kind of contacts you when there's an issue which comes up with the patient, and then your goal is to make sure that you get people in touch with the right other individuals to get care done. Mm-hmm. So I can't stress that enough. Mm-hmm. Focus on just being a decent, communicative, nice, personable person if you are in medical school. The books and all of that, that'll come with time.
Mm-hmm. So thank you all. And now there are some harder questions. So we heard a lot, and we'll have time for questions from all of you, but we heard in some way some similar aspirations and experiences of relying on one another, having teams that you respect, that you are grateful for, that work. I want to hear a little bit about just an instance or two when things don't go right. What is it that makes a team dysfunctional? Because we want to drill down and see what do we have to be able to know and do in order to make it dependably effective. And we know they're not always. Anyone have some? Please.
I was just going to say communication.
Mm-hmm.
That is the key.
Mm-hmm.
You have to be in constant communication, and that's not just reading each other's notes. That's picking up the phone, or I might call the attending and say, listen, I want to meet with you and the resident and the social worker and the CNS and whomever else,
right,
in order for us to really develop this plan together and
right,
really engaging everyone and trying to get their participation. And I think that helps to continue to build that team,
right,
as long as you're communicating with one another.
Mm-hmm.
Also, I think communication, but I think also we all have jobs to do. And I think that there's a lot of blurring. And I think that if you have an understanding of what the other person's job is,
Mm-hmm.
you sit in her chair or his chair,
Mm-hmm.
and then you sort of develop more respect for what they do. Because with us, we have outpatient, we have a chemo floor, an infusion center. And when things go wrong, it's like a snowball.
Mm-hmm.
And I think it comes back to communication, but then also understanding each person's piece and how it fits in with everybody else.
Yes. There was we were doing some interprofessional seminars for the inpatient oncology unit some years ago. And we gathered together the attendings, the fellows, the chemotherapy nurses, the staff nurses, the social workers, the chaplain. And we had, I think it was twice a month, seminars. We mostly did narrative work, me being who I am. And we did some reading and writing together and coming to know something about one another's situation. So I remember on the first meeting, the oncologist, the medical oncologist, says to the chemotherapy nurse, "Oh, I didn't know chemotherapy nurses did that." Whatever it might have been. Whatever it might have been. And then it couldn't have been more than 3 or 4 weeks later that the same oncologist says to the same chemotherapy nurse, "I want you to be my nurse when I'm dying." So the knowledge of one another at that level of meaning can happen very quickly, because all this work we're talking about goes on in this crucible I mean, there's nothing more dramatic. There's nothing more dramatic than this work you're just hearing about, even though sometimes to an outsider it might seem kind of dull. But every now and then you have this sense of, oh, not only do I know what you do, but damn, if you weren't here, nothing would happen. And what we want to figure out together is how to make that more possible and regular. Huh?
So I like call and response or having crowd participation. So quick, you guys are all in healthcare professions, right, or in school currently, right?
They're medical students or nursing students.
Okay, perfect. So in terms of your rotations or people who you've worked with, how many of you have heard somebody say, like outside of their profession, so a doctor say, that nurse is terrible, what a jerk, or those nurses are jerks, or someone who's rotated with nurses heard, those doctors are assholes. How many have heard that before? Okay. So I certainly have as well. I think we all have. And, but there's a problem with this kind of dialogue, right? Not the fact that it's just offensive, but more so the fact that we can't all be assholes, right? The nurses and the doctors and the care coordinators and social workers and the physical therapists, we can't have a hospital which is just full of jerks, right? That's impossible, right? And so and what I'm trying to highlight here is the fact that there is this tendency in healthcare, and it extends to many other professions as well, but especially in healthcare, to silo. I'm a quality improvement guy, and one of the things that we always talk about is basically that one of the biggest issues that occurs is when you start thinking that another group is specifically not doing their work or not competent or actively trying to do poorly for patient care, which clearly is not the case. We know that when we get to know people on an individual level, we know that they're hardworking, that they're smart, that they want to do what's best for the patient. But it's very easy when we're kind of working within our specific disciplines, our specific silos, to say, you know what, those people out there, they're jerks, they're not trying, we're the ones who are working hard here. And that's when you start having breakdowns in communication. When you start seeing the other people who are around you as the enemy and not as people who are on your team who are trying to get the same goal accomplished. So I really encourage everybody, take a step back sometimes. Think about that when you start hearing that type of negative dialogue. And think about the fact that the other people around you are probably doing their best and trying their best for the patient just like you are. It's more so the fact that there's probably some type of misunderstanding or breakdown in communication which is causing you to feel the way that you are.
Yeah. Questions, comments? Please.
Well, I know that you can't have the whole hospital be there. Certainly sometimes people really are there. But how do you handle that?
Yeah. Jonah?
Hi. I think that everyone in the hospital is extremely overworked and usually under a nice amount of stress. And whenever you interact with them, they're by definition assuming that you want them to put something that you need ahead of something that they need. And something like that is extremely easy to trigger someone feeling like, oh my God, I can't handle this, and then a response that you probably don't want. And what I think we were all talking about the importance of communication, and I think a crucial element of communication is acknowledging when you talk to someone that you understand their workload and that you appreciate what they're doing for you. And saying something politely and nicely and with a smile actually goes a tremendous way. You see jerks become non-jerks, and other people become not like that either. And so I think more often than not that has always been successful. And if it's not successful, then you just move on because some people are just always going to be like that, and it's their problem, not yours.
You want to add to that,
I
please?
just wanted to add something. I think that it's important when you're trying to develop a good, strong, cohesive group that you have a culture of feedback.
Yes.
And I think it's important, when you're having certain encounters that person is made aware that, this is, how I perceived your reaction or what have you. And I think that's something that I know we try to do, and I always try to stay in communication with our leaders. If it's problem in a particular discipline, making sure that we give that person that feedback.
Of like all the oncology body parts, the breast group is really a pretty cohesive group. And we try to figure out how come, like why is it that we don't have a big
Yeah.
turnover, how come
Yeah.
people stay. And sometimes there is a personality that's a little bit difficult or disappointing and it's interesting, one of the attendings I work with, who was probably one of the most temperamental I'd ever met in my whole life. You now know where I all work. Took, what is it? It's resolution management or and no, she's
Conflict
terrific.
resolution.
She's terrific. And what she does is she brings the person in who's having a hard time and says, "You're having a hard time. Tell me what I can do to make it better." And that has had like a tremendous amount of effect on sometimes somebody who feels maybe disgruntled or feels overworked. Is the appreciation that it's noticed and that something could be done to make it better.
And along the lines of communication, what I think is so important in the healthcare system is to have, again, a movie reference is that circle of trust. And to be able to understand that no question is stupid, and when you don't know the answer to somebody, that you have the ability to ask that question so that you don't develop kind of that jerky-like attitude where I think I know what it is, and then you have 10 people telling you that that's not what it is.
Right.
And that you have those other 10 people kind of kindly guiding you in the right direction.
And just it's also really important to be approachable, and to always remember we were all students at one time. We have attendings on our floor. No one is intimidated to approach them and ask them a question about anything, and it's great. And the patient benefits in the end from that. And even for nurses, you know, as a night nurse, 5 in the morning, all the polite med students are coming in to find out what happened overnight with the patient. Take time, 5 minutes, and be kind to them and share information, and not, oh, the med students are here, it's 5 in the morning, you know. It is. It's just, we all should be approachable because it's a learning environment.
Yeah. Please.
I'm curious, I've heard a little bit about the role that the unions factor in hospital staff, and I'm really curious to hear what your experiences have been in terms of how unions either help support you professionally, and then also possibly places where, I don't know, there could be a little more traction around this issue.
I'm union. I've been in the union for 13 years. Unions are tricky because they're good because they'll protect you, but they also can keep people in positions longer than maybe they should be. So it's difficult in nursing. It's pretty difficult to be terminated here, to be honest. So that's just my personal opinion of unions. So that's challenging. You have to have a certain amount of, I'm not management, but a certain amount, you need to be written up a certain amount of times and have a certain amount of warnings and different things before you can be terminated. So that's my opinion of unions.
Unions have also given pharmacy a bad rep. It's very prohibitive of what their job descriptions are. So myself, I'm clinical, I'm out on the floor. There's staff pharmacists in the satellites dispensing the medications, making the medications, and our jobs can't cross.
Oh.
Because if I start doing union work, then they can start doing my work, and it becomes a more blurred line. And so I think that in our hospital specifically, we get a bad rep because they don't want to advance their education. They don't want to be clinical. And so when a student or a resident is calling up the pharmacy, they may not get the same answer that they would get if they had us on rounds. And our education is a little different also, so it creates a lot of barriers.
Right, so that within any one of these disciplines, there are any number of subgroups which can also have conflict among themselves. Indeed. We just have a few more minutes. Are there others? Please.
I have a question. So all of you introduced yourselves and described your own roles. I was wondering if any of the other people on the panel had what your reactions were to hearing your coworkers describe their role, and whether there was
which is a good sign. Because indeed, in the working itself becomes, it is produced, this knowledge that we're hoping we all can accomplish. Does Columbia University Medical Center and NYP have a culture of team? Well, that's vexed. But this place where we work, do you think, and the experience here is phenomenal. Do you think our institutional culture allows for, encourages, makes room for, supports the kind of teamwork that you are describing?
I'll just say briefly, I think day to day on the wards there is. I think it doesn't. I think on our daily life, interacting with anybody, you don't even know necessarily who's an NYP employee or who's a Columbia employee. I don't know too much about this, but bigger picture, I understand that there are certain conflicts.
Yeah. No, I'm talking in general, kind of teamwork among nurses,
Yeah,
pharmacists,
so
social workers.
I haven't noticed, at least in my experience, no traction on daily life.
Yeah.
It's very collegiate.
You know?
I do, I really do.
Okay.
And even within the
Take a mic.
departments, it's a teaching institution.
Yes.
It's a research institution, and we very often see interdepartmental working together. Certainly, when I speak with pharmacists, whether it's NYP, social workers, I feel like there's this feeling of everybody working together.
Okay.
All right, so since I'm in my last year here, I figure I can be a little bit more blunt about things. So I would say that I do believe that this institution does have some difficulties with its culture in terms of its teamwork. I do think that I have been at other institutions where there is a more collegial environment between nurses, doctors, care coordinators, the entire team together. I think, though, that, again, as trying to think from a quality standpoint, that this is not something that is, again, based off of individuals, because the time when I've spent time getting to know individuals, even ones who I formerly thought may have been more difficult to work with, I have then developed a strong working relationship with them. I think that really, our goals as both an institution and then also what we can try and do as individuals is to change the system and the culture that we work in. Some of the things that I have wanted to try and bring about here and that could potentially, I think, improve some of the circumstances. Quite honestly, all of our work areas are very isolated. So, for example, the medicine residents work in a resident workroom that is actually locked with a code in order to get into. Some of the nurses occasionally will learn the code, and then there's almost this invasion of what is our home base as a thought. And the nurses work around the nurses station, and that's typically where they are. So we're not sitting next to each other. I've seen residents, call literally from a workroom when they could literally just open a door to talk to a nurse who's outside on the floor. So there are issues which could be improved, and I think that starts with basically I think everyone up here has talked about how learning a little bit more about who the other people are, having kind of face-to-face interactions, learning a little bit more about where they're coming from, what their role is going to be important. And then quite honestly, I think that it's our job as an institution and people to advocate for things potentially like greater shared working spaces, greater access to face-to-face communication, and other types of events which might be able to bring multidisciplinary teams together where they can actually get to know each other on more of a personal level.
I just want to say that I totally agree with what he just mentioned. I remember I came from Texas Children's, and I was like, we had a holiday party, and it was only the nurses. And where I came from, everybody was at the party, and I thought that was really interesting, just as a small thing. I just feel like you said, we could do a much better job in trying to foster the teamwork amongst the different disciplines.
Okay. So, thank you all for your attention. One more?
Yeah, sorry, just going right off of that. Can you talk a little bit about what you think can happen at an educational level
that one thing that you're already doing, but if you could expand upon it, I think it would be even more wonderful. This is my second year participating in the clerkship program, which I think has been a phenomenal opportunity for, right as you're starting medical school to just hit the ground running, trying out different disciplines, everything from everyone up here to pastoral care, physical therapists. So
And
I think
that's the first year medical school in FCM where you have 6 weeks and 6 weeks on different clinical services.
So I've had for 4-hour afternoons, 1 afternoon a week, students shadow. So I think if there's any way to expand that beyond, that would be wonderful. Because the feedback I've gotten from the students who've experienced it has been very positive.
Yeah.
And I've also felt really good about it because it's like, aha, you're a first-year student, you're a medical student, you already know what social work is about. And
Yes.
so, and it's important to understand each other's roles early on before suddenly you're in the hospital setting 8 years out, and then you're learning. So that's just something that I found to be really beneficial.
We also, in Choney, we started a nurse elective for the residents. So they can choose it as an elective, and they shadow a nurse on my floor for 3 shifts, in the PICU for 3 shifts, and the ED for 3 shifts. For their whole shift, they go into every patient's room,
Wow.
every medication,
Yeah,
every
yeah, yeah.
change, and we've had phenomenal feedback.
Wow.
I will
No.
echo that.
This is residents. This is residents.
Okay, our time is up. You know where you're going? Yes, a hand. For the